So, welcome everyone to episode of Prostate Disease podcast. I'm here with Andrew Armstrong and Amanda Broderick to talk a little bit about the WNT pathway. So, can you please start introducing yourselves and tell me a little bit more about what led you to this interesting research, please?
Yeah. All right. I'll start. I'm Amanda. I'm a hematology and oncology fellow at Duke. I'm currently actually taking a break from my fellowship as a chief resident for the internal medicine program, but then I'll return to my fellowship next year. I think quite a few things that led us to look into the Wnt signaling pathway. Wnt signaling pathway alterations have been implicated in multiple cancers, probably most well known in GI cancers due to APC mutation in the hereditary cancer syndrome FAP, but also, is known to have a role in development and maintenance of stem cells, of regulating cell migration and cell-to-cell adhesions, and also have some implication in immune system evasion as well. So these all made it an interesting pathway to look at.
Yes. So just to introduce myself, Andrew Armstrong. I'm a GU medical oncologist at Duke and worked with Amanda on this project. In addition, we brought in a very large multi-center team called PROMISE. So we looked at PROMISE as a large multi-institutional database that we created many years ago, now has 2,500 patients, all of which have advanced prostate cancer. And because Wnt alterations at the genetic level are relatively common, like 10 or 11%, we looked to the PROMISE data set as a way to look at whether patients with Wnt alterations had a different clinical presentation and different outcomes and different co-occurring alterations. Certainly there's Wnt pathway inhibitors that are being studied in a range of solid tumors. So if we can define how these patients are doing, we might be able to identify, those patients prospectively for future interventional studies.
So, when tell me something more about your results, because one of the interesting results actually was that patients with the WNT alteration had a higher prevalence of liver and lung metastases. So, how do you explain these important findings, and also what are, in your opinion, the important findings that people that are listening to us, and specifically residents that may not be as aware of these kind of genetic alterations? So, which are the important findings of your research?
Yeah, I think our biggest finding was, like you had mentioned, the association with visceral metastatic disease. And we really found this through all time points that we looked at. So this was for Wnt altered versus non-altered patients at time of diagnosis, at time of first metastatic disease, at time of castrate-resistant metastatic disease. We found it throughout all of these time points, but interestingly, which this was a more surprising finding, despite the association with these increased visceral metastatic disease, we did not find any change in survival outcomes, which was something we delved a little bit more into, and we can talk a little bit more about. I think there's a few potential explanations for that, but I think the biggest findings that we noticed really was that increase in visceral metastatic disease, as well as an increase in certain co-occurring genetic alterations with Wnt pathway alterations. So we found a higher prevalence of co-occurring RB1 loss and mutations, AR mutations, SPOT mutations, and PIK3CA mutations as well.
And
Just to
Andy,
add
what? Yeah,
a
go
quick
ahead.
comment to that is that there are some genetically engineered mouse models that incorporate Wnt alterations. And when scientists have created animal models of prostate cancer that have Wnt pathway genetic alterations, that creates more visceral metastases. So we actually cited that in Amanda's very nice paper, that now we have a clinical correlation to those preclinical findings. How it promotes metastatic disease is a little unclear because Wnt does many things, as Amanda said. It turns on many signaling pathways that regulate cell proliferation and division and cell cycle. It can co-occur with other alterations that can promote lineage plasticity, like RB loss. It also creates more immune evasion. Wnt pathways linked to escape from the immune system, which may allow for that kind of pattern of spread. So all those things are possible.
And so another interesting thing that so you found these common genetic alterations with, as you said, RB1, AR. Do you think that your sample size is enough to evaluate different combinations? Meaning that do you think that we can conclude a little bit more on this aspect?
I think at the time of our analysis, no, we did do some side analysis looking at co-occurring WNT and SPOP, for example, versus co-occurring WNT and RB1 cohorts. We didn't have enough patient numbers to really to be able to make good conclusions about it. But we did actually see a trend in improved overall survival when we compared the WNT SPOP co-occurring alterations versus the WNT RB1 alterations, for example, but we just didn't have quite enough numbers to be able to make a good conclusion on that.
Okay, so and the one of the most interesting questions for the ones who are listening to us is, what do you think about a target therapy targeting these genes? Do you think that it's something that it's imaginable? Is something that you think it might be possible? Like we are seeing a lot now with all these new target therapies that seem to lead us to a personalized medicine, something that we've heard. I mean, I remember since I was a med student that this was the El Dorado of medical oncology. So what do you think about it?
Yeah,
Yeah,
I can take that one. Certainly, the Wnt pathway is complicated. There's genetic mutations that hyperactivate Wnt signaling, but then there's pathways that are activated without mutations, and prostate cancer has both. So it has about 11-12% of patients have activating point mutations or deletions and suppressors of Wnt signaling that hyperactivate the pathway. But then there's also, at the RNA sequencing level or protein level, there's also groups of patients that have activated Wnt signaling. Both the canonical and the non-canonical pathways are activated even in the absence of mutations. So we're just now getting to appreciate those differences. And most of our inhibitors inhibit the canonical pathway, and that would be important for patients that have these alterations. And that's under study right now, for example, in colon cancer and in melanoma. You can either have kind of Wnt ligand decoys or antibodies, or you can use what's called porcupine inhibitors that block Wnt export to the cell surface. So a lot of these are still in phase 1. They haven't really been progressed to the point of being tested in prostate cancer, to my knowledge, and are largely been focused on more Wnt-driven tumors like colorectal cancer, as Amanda said. So there's a lot of normal biology that Wnt is important for, like bone health. So they've seen some loss of bone density and fracture risks with targeting the Wnt pathway. Certainly when we see patients with prostate cancer, we're focused on bone health as well and using anti-resorptive therapies like denosumab, zoledronic acid. That may mitigate some of those risks of Wnt inhibition. A lot of your GI system is dependent on the Wnt system, so GI toxicity. So we're still working on the safest way of tackling this and then the right patients. So like I said, the non-canonical pathway is really targeted differently. So there are non-canonical like ROR inhibitors that are being tested, which is kind of outside the scope of our paper, of course, but that's generally where the field is heading towards either the canonical or the non-canonical.
And do you think that for the time being, given your results, meaning that patients with alterations have obviously higher risk of visceral metastasis, do you think that it might reach the level of do you think that we can find this alteration in the early stages of the disease so that it can become a biomarker? Or do you think that it is something that actually you have later on, like a later mutation?
I think that's a good question. That's something we thought a little bit about as we looked at our data because our group was a bit heterogeneous where we had NGS that was collected for some patients was collected at time of diagnosis and some patients collected later on in the disease course. So I think it's hard from our data to say, were most of these Wnt alterations a later mutation that happened at the time of metastatic disease, or did most people have it at diagnosis? Though I will say, people at diagnosis, it seems like we had it. I'm trying to think of how to say it, but I think it seems like people have these Wnt alterations in the non-metastatic setting too. So I don't think it's exclusively just associated with metastatic disease in that regard.
Yeah, I agree. These are not germline alterations, so it wouldn't, be
Right.
detectable before the diagnosis of cancer. These are somatic tests, either done on the prostate or metastatic or sample or ctDNA. And so the tumor has evolved this. If I knew a patient had a Wnt alteration in his tumor, I might be more aggressive about soft tissue imaging to rule out visceral metastatic disease because of the 3 to 4 fold higher risk of that finding in our case series at all stages. But most of these patients are likely to have higher risk disease. We also found an enrichment for intra ductal features. So these are just features that suggest a more aggressive pattern of spread from the beginning, and it may change how you image. It's already recommended in most national guidelines to do NGS testing on the tumor, particularly when a patient develops metastatic disease, because that could open the door to other precision therapies. MSI high disease was enriched in Wnt patients. That could open the door to PD-1 blockade. But right now, Wnt alterations by themselves are not considered actionable. We don't have specific tailored therapies that are known to improve their outcomes, but this might be useful to enroll that patient in a clinical trial.
Okay, and so in the near future, what are the next steps to go further on the research on the Wnt pathway? So do you think that it's more to analyze the effects in a metastatic population in a earlier phase? What are the next steps given your results right now? What's your interest?
And so I'm interested in understanding, the difference between the canonical Wnt, which is our paper, and the non-canonical Wnt, which is really something assessed through proteomics and RNA expression analyses that would be beyond the scope of our paper. Inhibitors of both of those pathways are kind of the next step in testing whether those inhibitors can rescue some of the adverse consequences of Wnt pathway activation. So I think clinical trials would be a great next step of therapeutics for patients that have either Wnt mutations driving the canonical pathway or Wnt pathway activation driving non-canonical. For example, enzalutamide resistance has been clearly linked to Wnt5a secretion, and that promotes enzalutamide resistance, but that signals through the non-canonical pathway. And so no matter how you target the canonical pathway, you've got this parallel pathway that would be unchecked. And I think further validation in other larger data sets. Rhonda McKay, who is a co-author on this paper, had a nice companion paper looking at a larger commercial data set with RNA sequencing that also looked at Wnt pathway and found similar prevalences and findings, which was interesting.
So now a more wide question for me. So, now in the past 10 years, we have several treatments, target treatments, and one of the latest paper is actually a little provocative, one of the latest editorial published, saying that maybe we're enrolling a lot of patients to test a lot of different drugs, and so the human cost of all this research is a little high. So how do you, I'd like to have the answer of both. How do you see the landscape of prostate cancer drugs evolving? I mean, how do you see with all these drugs, how to navigate across them without getting lost? Because it's a little difficult. There is no data exactly on how to sequence all these patients. And what I think what the message is probably of your study is that there is a lot of genetics and a lot of molecular stuff behind the cancer. So it's probably the reason why you found some interesting results and some are not that clear is probably because all these diseases are not exactly the same. So probably I really like to know from a medical oncologist point of view, what do you see in a 10 years time and what do you hope to see probably more than what you see?
I think it's certainly challenging in prostate cancer that's so heterogeneous and there's so many different alterations. And I think kind of having a better understanding of that co-alteration landscape and how a lot of these different alterations maybe work together or work against each other to create these different phenotypes of disease, to figure out what to best target. We also have planned, I think, a multivariate analysis using a lot of the PROMIS data, which will be helpful. And I think parsing out exactly which of these mutations are most relevant clinically and especially of these potentially targetable ones so that we're targeting the right things and not just any potential alteration that we find, because we certainly find many like you alluded to, and which are the ones that are most relevant to our patients.
Yeah, I agree, Amanda. And the purpose of precision medicine really is to optimize care delivery so that you're giving effective therapies to those who benefit and avoiding ineffective or cost ineffective therapies that are possibly toxic to patients unlikely to benefit. A PARP inhibitor is a great example where, for example, olaparib really prolongs survival in patients with homologous repair deficiencies, particularly BRCA2. The same might apply to Wnt inhibitors, that you wouldn't want to necessarily test Wnt inhibitors in all patients, but only likely in those that have that pathway activated. And that might be 10 to 15% of patients, but that's still a big piece of the pie. There are some therapies that work broadly, like our AR inhibitors, because AR is so broadly active, or PSMA-directed therapies, where PSMA is widely expressed, where you don't necessarily need a precision diagnostic as much. But for, I think, Wnt pathway inhibitors, you're going to need this kind of genetic test, or at least pathway analysis, to tell you, who's going to possibly benefit.
And the last two questions, one is a little provocative, saying, do you think that in this setting of precision medicine, randomized clinical trials are the key, or should we consider other kind of statistical as well to avoid randomizing and giving actually placebo to all these patients who actually don't benefit? How do you see that? Also, I'll give you also the other side of what I think might solve this problem. Is one is AI and the other is big data. So do you think that these two types of new technologies that we are facing and understanding may solve this problem of always randomizing patients, which is a little ethically, it's a little challenging given the high number of patients that have to receive placebo before getting a good conclusion?
Yeah, I can start with that. I mean, I totally disagree that it's unethical to do a randomized study. I mean, if you look at the 25 randomized phase 3 studies of docetaxel combinations, all 25 were negative. And so if you were in those trials, you actually did better because you got the placebo. Those patients, because those studies failed to show efficacy. And, it's really important to control for baseline confounders and differences, and doing a randomization ensures balance in a population so that you can test the efficacy of a drug. And allowing the drug to just be tested without a control group is like doing an experiment in the lab without a control group. It wouldn't pass muster, and AI is not going to solve that. So you really do need appropriate controls. Now, that doesn't always mean that patients will get a placebo. You could have an active comparator. You could do a physician's choice comparator. whatever the standard of care is, you could try to beat, and that's not a placebo necessarily. It could be a combination with or without a placebo, so that you're at least giving the patient the best standard of care at that time. So it does depend on the context in which you're studying. But for example, a Wnt inhibitor, we actually don't know if the Wnt inhibitor is going to benefit patients with Wnt mutations. You could look at enzalutamide or abiraterone plus minus a Wnt inhibitor, for example, to see if you could delay or prevent resistance so that everybody gets something. But it could be better for the patient not to get the Wnt inhibitor if it's toxic to the GI system or the bone and bone marrow. So there you really do need controlled studies to assess the net risks and benefits. And I don't think AI is likely to solve that anytime soon.
Well, that's important. I think it's an important message to give, particularly to residents, because I think that this is important to understand. I think I agree with you. It was more a question to highlight how important it is to do randomized clinical trials.
Yeah.
The only latest innovation is probably artificial data. So that is something that we might hear a little bit of artificial or synthetic data that sometimes may help somehow, especially in small group of patients, because probably one of the only limitations of randomized clinical trials is when you have a very small population, so you will never get, because there are not enough cases. So some scientists are just saying that with all the data that we have, machines are able to create similar patients that may be very much alike, and they may predict the outcome. But it's a little difficult to understand, especially for those who don't do engineering and informatics. But I think that that's an interesting future point for. As I said, the problem is small populations, probably small with where you don't have actually enough patients to reach the statistical significance. But I think that we will still be tuned on this channel a lot to see what happens, because I mean, I always think that when I started medical school, there was nothing for metastatic disease behind ADT. So something amazing that has happened in the last 10 years or so. I think that this is the main point, and precision medicine is probably the only way to go, probably. What do you say, Amanda? Do you have any more comments on this?
No, I don't think I have too much to add. I was just, I was thinking about I had looked up some of the other phase ones recently, and I think there was a phase one of a monoclonal antibody that it would inhibit, the canonical Wnt signaling pathway in breast cancer. And similar, like we had been talking about, it had some potential efficacy there, but then high rates of fracture and high rates of those bone side effects, which is what has kept it from moving on, which it may, think about prostate cancer, and the similar bone risk. It kind of, it makes you wonder if that is going to end up being one of the limiting side effects when we try to target that pathway.
Yeah, well, we almost obviously in the early phases we focus a lot on results, and sometimes obviously, as you said, side effects may be a little limiting for these kind of drugs, and but probably, I mean, we will see what science will bring us to target even more. I think that a little bit of what we saw with molecules targeting only cancer cells may solve some of these toxicities, but I mean, I think we're just at the beginning of a very interesting journey. So I'll give you just the final words to conclude on what you want to say about your research, and we'll close the podcast. I think that we have done a very nice trip along your paper, and I think that people will very much enjoy a very difficult topic, because probably reading the article is just not that easy for everyone. So I think this podcast might be useful for some, probably for urologists, but I don't think that a lot of urologists are all into these topics, especially nowadays. And for residents, for sure, this is very important to understand what is behind all the molecular and genetic pathways behind prostate cancer. So please, Andy.
Sure. So just to conclude, I mean, this was a great example of the use of real world data and Promise as a way of accessing real world data from 20 different centers around the United States to look at these kind of rare mutations in a disease to look at outcomes. So WNT is 11-12% of all prostate cancer, which overall doesn't sound like a lot, but still is tens of thousands of men every year in the United States. So putting together real world data into big data sets can teach us quite a lot about a disease like prostate cancer that you wouldn't have otherwise known. And so just to put in a plug for Promise, we've now, developed a number of publications related to genetics of prostate cancer and health related outcomes now. And so Amanda did a great job leading this WNT project, and we hope to take it to the next level, as we talked about with therapeutics.
Yeah, I think like Andy just said, I think this is just such a good opportunity having this big multi-institutional consortium and having access to all this clinical genomic data as we try to look at some of these less common alterations and try to focus more on these potentially targetable areas of prostate cancer.
Okay, so thank you, everyone. This was episode 10 of Prostate Cancer Prostate Disease Podcast. So a big thank to Andy and Amanda for giving us this fantastic podcast and getting us more inside of the genetics of prostate cancer.